Bismillahirrahmanirrahim. Today we will have case quiz number 29. Case data: 52 years old male. He is working as coal miner. He has bilateral wrist pain, insidious onset, progressive difficulty of breathing. By examination, he has bilateral MCP joint synovitis. Investigations: ANA titer is negative 1/20. Anti-CCP level is highly positive. Hand X-ray show marginal erosions and early subluxation of the metacarpophalangeal joints. CBC and comprehensive metabolic panel are normal. Chest X-ray shows bilateral upper lobe nodularity and interstitial fibrosis. So the case is actually a complication of rheumatoid arthritis. But what is the diagnosis? The diagnosis is, yes, of course, you are right. It is Kaplan syndrome, which is a complication of rheumatoid arthritis mainly for the coal miners. Kaplan syndrome. This is pulmonary fibrosis usually on coal miners who have rheumatoid arthritis. The syndrome is named after Dr. Tony Kaplan, who was a doctor on the pneumoconiosis board in Cardiff. There are few earlier papers on the subject calling it Kaplan syndrome. It seems to have been discovered in the 1950s. Regarding the epidemiology of Kaplan syndrome, it was said to affect 1 in over 100,000 people, but the incidence is now falling as the coal mining industry itself has been in decline. The prevalence is so low that much of the literature is case reports rather than trials. PubMed lists no more than 20 papers in the past 10 years. About the risk factors, rheumatoid arthritis is a systemic disease and not just a disease of joint. The combination of RA and exposure to coal dust produces this condition. It develops especially in miners working in anthracite coal mines and in persons exposed to silica and asbestos. There is probably also a genetic predisposition, and the smoking is thought to be an aggravating factor. Presentation: regarding symptoms, there is cough and shortness of breath. In addition, there are the features of rheumatoid arthritis with painful joints and morning stiffness. Signs: there are features of RA including tender, swollen metacarpophalangeal joints and rheumatoid nodules. The nodules may predate the appearance of RA by several years. Examination of the chest may show diffuse rales that don't disappear on coughing or taking a deep breath. The differential diagnosis: the combination of rheumatoid arthritis and exposure to coal dust are essential for the diagnosis, but silicosis and asbestosis must also be considered. The X-ray appearance can resemble that of tuberculosis. In RA, lung disease can develop even in the absence of dust exposure. It includes interstitial fibrosis, pleural effusion, pulmonary nodules, pulmonary arteritis, and pulmonary hypertension. The investigations needed for this case: chest X-ray show multiple round well-defined nodules. usually 0.5 to 2 centimeters in diameter, which may cavitate and resemble TB as we said before. CT scanning gives a better picture of cavitation. Spirometry may reveal a mixed restrictive and obstructive ventilatory defect with a loss of lung volume. There may also be irreversible airflow limitations and reduced gas transfer factor. Rheumatoid factor, anti-nuclear antibodies, and non-organ specific antibodies may be present in the blood. ESR or CRB may be elevated. X-ray of the affected joints will show the feature of rheumatoid arthritis with bone erosions. Associated diseases, TB must be sought and treated if found. So TB is both a differential diagnosis for the case and also a potential combination for the case. So the presence of Kaplan syndrome is not an exclusion of TB because both conditions may be present at the same time. The management is non-pharmacological and pharmacological. Non-pharmacological includes exposure to coal dust must stop. Physical treatment should proceed as for rheumatoid arthritis, and the smoking should stop. So physical treatment, exposure stoppage to both coal and smoking. Drugs after exclusion of TB, steroids are used. Treatment of RA will include the same treatment for rheumatoid arthritis either by conventional synthetic DMARDs or biological DMARD or target-specific DMARD. Complications. TB is a differential diagnosis and an associating or a potential associating disease. So TB may coexist. There can be complications from steroids and other forms of treatment, whether non-steroidal anti-inflammatory drugs or DMARDs. Prognosis, this is the same prognosis for RA, but severe form of RA. Severe respiratory disability is uncommon, but massive pulmonary fibrosis can progress with time, yes. Spontaneous remission of the lung can occur. So the two scenarios are expected, either to remission or to progress to massive pulmonary fibrosis. And early treatment is mandatory for these cases. Prevention. People with rheumatoid arthritis must not be exposed to additional risk factors for lung diseases. And thank you very much for your attendance, and we will see you tomorrow for the case quiz number 30. Wassalamu alaikum wa rahmatullahi wa barakatuh.